All right, everybody. We are kicking off our quarter two webinar, the Eye on ctDNA. And I know it's a little bit of a pun for us to use that all the time, but we're so excited to have the guest speakers that we have today. I wanted to start off by thanking you guys, our audience, everybody who registered and who has started participating. Um, I am so grateful to you guys for, just playing an active role in your care and in what you learn as patients and caregivers in the uveal melanoma community. So we here at A Cure in Sight are so excited to bring this webinar topic to you about ctDNA and just kind of helping you understand what this test is and how you might potentially bring it to your doctor as something that you could utilize in your own medical journey as a uveal melanoma patient. So to kick us off, I want to just say huge thanks to our sponsors. We have quite a number of sponsors this time. We've got Natera, Castle Biosciences, Aura Biosciences, Delcath Systems, IDEA Biosciences, and Immunocore, who are all helping to sponsor this webinar and who are just making this possible. So big shout out to them for making this possible. And thank you to all of you guys who are registering, who are here live and listening. As we get started and I bring on our guest, we are going to have a short presentation to start, and then we're going to have an opportunity for you guys to ask questions. As you have questions, as Dr. Krainock is presenting, as you hear, the doctors discussing, please make sure to put those in the Q&A box. There should be a section at the bottom where you can click to ask a Q&A, or you can ask in the chat as well. I will be monitoring both of those places, and we will answer questions throughout the end of the portion of the webinar. We do have a hard cutoff at the hour and a half mark, or the hour, or yeah, hour and 15-minute mark. Goodness, I gotta calculate time here. But as you guys are popping into the webinar, drop in the chat where you're from. You guys should be able to chat and just say hi. But with that, I'm going to go ahead and bring our friends and our guests into the webinar. Thank you guys for joining us. We're going to actually do a little bit of an introduction roundtable style. So you guys know who I am. I'm Danae Peterson with the Cure Insight, and I'm your host for this webinar. And my kind of co-host in this webinar is Dr. Michael Krainock from Natera. So Dr. Krainock, say hi.
Hi, everybody. Mike Krainock, Medical Director at Natera. Super excited to be here. Dr. Montazeri, you want to go next?
Yeah. Hi. My name is Montazeri. I'm a melanoma oncologist at Mass General Brigham Cancer Institute and faculty at Harvard Medical School. I have a special focus in uveal melanoma. I'm really happy to be here, and thank you for the audience to join.
Dr. Ma?
Yeah, hi. Good afternoon, everyone. My name is Vince Ma. I'm a medical oncologist at the University of Wisconsin Carbone Cancer Center. Currently the co-faculty lead for melanoma and non-melanoma skin cancer. And one of my areas of special interest and focus, particularly in research, is also in uveal melanoma. So I'm glad to be here today to answer some great questions.
Awesome. Thank you guys so much for being here again, for just participating. And with that, let's go ahead and get started with Dr. Cranock's presentation, and we'll just learn a little bit more about Natera and the Signatera test.
Sounds great. Thanks, Danae. Can everybody see the slides okay? They coming through all right on your end? All right, wonderful. So once again, I'm Mike. I'm a physician scientist and surgeon by background. I've been with the company about 6 years now. I do a lot of work in melanoma and other cutaneous oncology, as well as thoracic oncology and head and neck oncology. I'm going to start just by kind of giving you guys a background of the product portfolio, so to speak, that Natera has. And then we'll kind of focus in on one piece of what we do, which is molecular residual disease testing, or MRD, and talk about how we do that and why we do that and what we're learning by doing that. We'll look at some data in all types of cancer, and then we'll kind of focus down from there and look at data across different kinds of melanoma to include some uveal patients. And then I'll pass it off to Dr. Montazeri and Dr. Ma to kind of talk about specific cases and their specific experiences they've had in uveal melanoma specifically. And then we should have some time for some questions. So hopefully by the end, you've got a really good sense of kind of what this technology is, the state of the field, and also the clinical data and potential clinical utilities in melanoma and uveal melanoma. So what you're looking at here is kind of a menu of tests that Natera has for cancer diagnostics. I'm actually going to start with the test called Altera. So that's a comprehensive genomic profiling test. This is what a doctor would get when they want to know if there's specific mutations that are actually driving the cancer forward. And the reason that we may want to know that is because sometimes there's drugs that we could use specifically for those situations, or there's clinical trials that you might be eligible for based off of those situations. So that's the Altera test. The Empower test is a blood test for hereditary cancers. So those are used for, or that's used, I should say, for patients who may be at higher risk because of a family history, for example, for certain kinds of cancer that run in families. Um, and then our MRD portfolio, again, molecular residual disease, and we'll talk about what that is kind of comprised of three different tests: Signatera, Signatera Genome, and Latitude. Signatera and Signatera Genome require tissue, and Latitude is just a blood test. So we use different features of cancers that are unique to cancers, but we can understand without actually having a piece of the tumor, if that makes sense, to track signals in the blood. We'll talk a little bit about more what that means. But for the rest of the talk, we'll kind of focus on the Signatera and Signatera genome. So to design a molecular residual disease test, we start with a piece of tissue. So what we're going to do is we're going to either get a piece of the cancer from a biopsy or a surgical specimen. We're going to take the DNA out of it and we're going to sequence it. We can do that in many different ways. Sometimes we do that through what's called an exome sequencing. Sometimes we do that through what's called a genome sequencing. But the important thing to know is that now we have a signature, hence Signatera, of the tumor. At the same time, we take DNA from a blood sample from the patient and we do a sequencing analysis on that. And then we compare those two sequences. And the reason we're able to use a tool like this is because there's an important principle here, and that is that cancer genomes look very different than the genome in our non-cancer cells. So, as a lot of the folks in the audience might know, cancers kind of accumulate different kinds of mutations in their DNA. And that's what we find. We find those mutations that are unique to the cancer that aren't present in your non-cancer cells, and then we track those specifically. And we only need the tissue the one time. So when we track those mutations specifically that are unique to the tumor itself, we can do that just through a blood draw. So tissue once, and every time we look for these signatures, it's just a blood draw. If you have any questions about that, you can drop them in the chat. We should have some time at the end to go through that more. But that's kind of the general principles of how we set up this test. We're looking for mutations in the blood that we know are coming from the tumor. We've been at this for a long time now, actually. So this test has been available since 2019. It was in development for years and years before that. Lots of very smart people working on this at institutions all over the world. We now have over actually 145 publications out there around this technology. We're actually responsible for over 90% of all the literature in this space as it pertains to tissue-informed, commercially available assays. All that work has now resulted in data that's reported out across 30,000 patients and 30 different tumor types. Over half of US oncologists have ordered this test, and that represents testing across over 300,000 patients as part of clinical practice. So the test is available. We have a very good team that helps support testing in the clinic to make sure that the tissue is acquired and the results are returned. And if there's any questions about interpretation, physicians and patients have a lot of support. You're probably thinking about payment. We do have Medicare coverages rolling in. As you may or may not know, you typically have to apply for Medicare coverage by indication. So you can't kind of do it once, you have to do it over and over and over again, at least in the case of these types of diagnostics. So that's a long process, but we commit a lot of time and energy to that so that we could get different indications approved for reimbursement by Medicare. It's a very similar process for private insurance as well. Private insurance will typically follow Medicare's lead. So over time, more and more of these approvals come through. You could see the ones that we have already. We have a bunch more we're working on every day now. But I do like to note that we actually don't balance bill patients. So as of now, there's no financial toxicity to testing. So you shouldn't get a bill, even if you aren't covered by Medicare. If you have private insurance and they decline to cover, we don't send the balance to you. That's how it is today. All right, so how do we interpret the results? So what you're seeing here are called Kaplan-Meier curves, KMs for short. You may have heard of these or seen these. And you're looking at two populations of patients that are separated based off of if our test is positive or if our test is negative. You could see those two lines do not look alike, right? They're different colors. They're also very far apart. And so what we're looking here is that the probability of being free of relapse, relapse-free survival over time based off of a result with our test. So you could see if you're ctDNA negative, that's MRD ctDNA negative, our test is negative, you're on that green line, right? You have a higher probability of being free of disease compared to if you're on the blue line, which is if you're ctDNA positive. So a lot of you may be familiar with biomarkers, what we call prognostic biomarkers. This is very powerful prognostic biomarker, right? We could tell very early and very accurately through this test if a patient's positive, they have a very high risk of having persistent disease that we'll eventually be able to see on a scan versus negative, they're much less likely to do so. Doesn't mean they never will. No test is perfect, ours included. However, you could see the likelihoods here across different tumor types of being free of disease or not free of disease over time. Can you make treatment decisions around that? That's the big question. Prognostic information is great. Can we do anything about it? It's a much harder question. It takes a lot of patience and a lot of time to answer that question. And that's what we're actively working on now. That's pretty much what my job boils down to, is finding out, can we do that? So I'm showing you data across a few different studies here and a few different cancer types. We'll start across the top with colorectal cancer. So we published this in a really big journal called Nature Medicine in 2024. And what you're seeing here, again, there's those KM curves. You're seeing that if you're positive by our test after surgery, it was better to get chemotherapy, right? The blue line has a better freedom of disease result than the red line. So if you're positive, you wanted to get chemotherapy after surgery. It improved your outcome in terms of your freedom from recurrence. If you were negative, you'll notice those lines don't look like the lines in the positive group, right? They're right on top of each other. What that means is there was no difference. So if you were negative by ctDNA and you got adjuvant chemotherapy, it actually didn't change your outcome in terms of your disease-free survival. So very exciting, right? This suggests you could potentially use a molecular test to make decisions about chemotherapy after surgery in colorectal cancer. As you can imagine, this is the type of thing we have to do over and over and over again before it becomes the norm, but certainly very exciting data here, and we hope what the future looks like. Similar data in the blue box there. That's now looking at adding another drug to the usual regimen of chemotherapy called celecoxib. You guys may have heard of that. You could see again, we have two different sets of lines. The lines on the bottom are far apart from one another. Those are the patients who are positive after surgery. The lines at the top are right on top of each other, telling you there's no difference between those patients with the drug or a placebo, and those are the negative patients. So again, selecting patients by ctDNA to predict who will benefit from an intervention. In this case, the addition of celecoxib, the standard adjuvant chemotherapy. Adjuvant meaning after surgery. And then again, looking at the bottom charts here, now we're looking at urothelial carcinoma, kind of commonly collectively called muscle invasive bladder cancer. Very similar idea. The curves at the bottom are the positive patients. The curves at the top that are kind of shaded out are negative patients. You can see the negative patients, those curves are right on top of each other, telling you there's no difference between getting a drug or not getting a drug. The curves on the bottom are the positive patients, and you see those are separated, right? You can clearly see at the bottom, those curves do not sit on top of each other, meaning there's a difference there. In this case, that difference was significant from a statistical perspective. And that means that we were able to give patients who were positive a drug, in this case, atezolizumab, and again, improve their outcome. Then this time, we're showing both freedom from disease and overall survival, meaning you were more likely to just be alive in general if you were positive and got the drug versus positive and didn't get the drug. Last slide on the same point, we kind of confirm this. Actually, in the last year and published this result in a big journal you've probably heard of, the New England Journal of Medicine, showing that you could prospectively, meaning ahead of time, pick patients who stood to benefit from, in this case, atezolizumab after surgery for bladder cancer. And this resulted just this week in a positive FDA approval for this test as what they call a companion diagnostic for muscle-invasive bladder cancer. So that means now you could use this test officially to select who stands to benefit from this drug, atezolizumab, after they've had surgery for their bladder cancer. So very exciting, and I hope this gives you kind of an idea of where the company's headed and the kind of things that we're working on. Moving into melanoma, this is all comers, all different kinds of melanoma. We recently published this. Again, we're looking at those KM curves. You could see we're looking at recurrence-free survival. Again, the proportion of patients who are likely to be free of disease over time based off of being ctDNA negative or positive. This is looking at melanoma patients after resection stages 1 through 3B. So again, you want to see that wide separation of those two different groups, and we see that here. Very powerful biomarker. What this tells you is that if you've had surgery for melanoma and you're found to be positive by Signatera and nothing is done, you're much more likely to have a recurrence. That's what this data suggests, right, in front of us here. And so can we leverage that to help us think about surveillance and treatment decisions in a more personalized way? That's the kind of the question. One thing you'll see over and over again is that, and Doctors Montazeri and Dr. Ma will tell you, as doctors, we use a lot of different things to think about your risk of recurrence. Classically, we look at the path report and the features of the tumor to make these risk decisions. And we base our recommendations for therapy after surgery or after radiation in many ways on the nature of the tumor and all these special features of the tumor that we're interested in. What we're finding out is that your status with our test is the most powerful predictor when you compare them to the things we classically use. So you can imagine this list could be a lot longer, right? We think about a lot of stuff. But in this particular case, compared to these other things that we looked at, ctDNA was the most powerful predictor of outcome compared to your stage, sex, and mitotic rate. This is actually some data from Dr. Ma. This is melanoma data, which now includes a subset of patients with uveal melanoma specifically. And what we're looking here is the change in the value of the circulating tumor DNA MRD test and how that correlates with what we call disease control and objective response. So you see three colors at the bottom: progressive disease, disease control, and objective response. As you could probably guess, progressive disease is the least favorable of those things. And what we're seeing here is that the change in the amount of ctDNA in the blood can help us predict which bucket you're going to fall in, right? So you could see the median change in quantitative value by those three categories. So patients with disease control had a median decrease of 82% in their quantitative value of ctDNA in the face of therapy, 88.3% for objective response, and then the complete opposite, right? A rise in progressive patients. So if the ctDNA is going up, this would suggest you have a much greater chance of having disease progression. Can we use that information? Does it add any advantage to your care? Can we tell that you're going to progress before you progress? And importantly, can we leverage that information to prevent that or delay that? Can we improve your outcome using this information? That's the job in front of us. So ctDNA decreasers had 30 times higher odds of disease control and 23 times higher odds of objective response. Very similar data presented in a different way. There's those good old KMs again. Now we're looking at progression-free survival and overall survival. We're asking about the change in the quantitative value of ctDNA after one cycle of a class of drugs called immune checkpoint inhibitors. You've probably heard of these and are familiar with these. We're looking at patients who went down after a dose versus patients that went up. And again, you see separation of the curves here for progression-free survival and overall survival. And then importantly, one step further, we asked about clearing your ctDNA. And what you really want to see is that you start from some quantitative value, you start on a treatment, you go down right away, and then shortly thereafter, it goes away. We can't see it at all in the blood anymore. And that's what you're seeing here. So you have three groups of patients. Green patients had clearance of ctDNA on therapy. Blue patients had a decrease but didn't make it to clear. And then orange patients had a rise. Better to be towards the top of the graph than the bottom. It means your probability of being alive and free of disease is better the higher you are. And you can see we have wide separation of the clearance curve from those patients who didn't clear ctDNA. So you can imagine we have now potentially a real-time biomarker to adjudicate response prediction based off of kinetic change very early on therapy, right? So we hope the future looks like we don't have to sit around and wait for scans to show us what's going on. We could very, very early, through a blood test, understand if the current medications that you've been prescribed are going to get you on the green curve, right? And if not, can we do anything about that? Can we change things? Can we intensify things? All in the name of improving the outcome. So I know that's a lot of information. I tried not to be too crazy technical with it. If you have questions, please, we can go deeper. But at this point, I will hand it off to Doctors Montazeri and Ma to talk about their experience with the testing.
Awesome. Thank you so much. Okay, who wants to go first?
I think Dr. Ma has some cool slides
Okay, Dr. Ma, we're going to put you
that
on the
are
spot.
easier to follow than Dr. Krainock's very academic talk,
No,
which
it
is
was great.
very fascinating.
Yeah, no,
Okay,
I
let's just
appreciate
review
Dr.
the part,
Krainock.
Vincent.
Yeah, going through a really wonderful overview of ctDNA and some of the amazing data, that we obviously see in, both melanoma, but other cancer types. So as you all know, it's such an evolving field, right? And so, I do have a few slides I'd be happy to sort of share with the audience just to kind of give you all a little bit of like a real world perspective of like how me as a medical oncologist is sort of using this test in real practice. And certainly the two examples I'll share are patients with uveal melanoma. So I'll go ahead and share my screen and hopefully you all can see my screen okay.
Yeah, you're good. You're full screen.
Excellent, thank you. So, just to share a couple of examples, this first case is actually a gentleman that I cared for in his 70s who was diagnosed with a right eye choroidal melanoma that was class 2 and PRAME positive and was treated with brachytherapy back in 2020. And so, unfortunately, during surveillance, because he was considered to be high risk, he actually ended up developing new liver metastases in January 2024. He was HLA tested and was negative, but after sort of reviewing a variety of different options available, he actually ended up opting for treatment with melphalan percutaneous hepatic perfusion therapy. And as some of you in the audience may know, it's also known as Hepzato as the commercial name. So what was really phenomenal about his treatment was he actually did very well with therapy. This screen here to the left is actually an image of his belly. And what you can see there with that particularly yellow arrow, it's actually pointing to a pretty large liver tumor. That's his melanoma liver metastasis. It measured about 7 to 8 centimeters in size. And after about one treatment of melphalan PHP or Hepzato, you can kind of see that the tumor shrunk by almost about 50%. And so as you can kind of imagine, in my practice, what I have typically been doing, and this is something I actually offer to my patients is, would you like to be monitored with circulating tumor DNA? Not necessarily by itself, but as sort of a complement, as a way to kind of see how well you're benefiting from treatment. And so the patient actually opted to participate in it. And as Dr. Krainock has sort of mentioned, what we did was we submitted one of his liver tumor biopsies to actually build the personalized assay. And we were actually able to assess a baseline circulating tumor DNA before he was started with Hepzato. So you can see here this little top blue dot here to the far left. And we serially, meaning we checked his ctDNA level throughout the course of treatment. And you can see here, just like what we saw on his CT scan, his ctDNA level actually downtrended quite beautifully well. So, a very nice complementary test to kind of how he is doing with treatment and a good way to monitor his progress. Now, of course, during the course of therapy, as he was getting additional cycles of melphalan PHP, we noticed that he's obviously continuing to do great. I mean, you can look here in the far right CT scan image here, his tumor shrunk quite nicely. And this was after 3 cycles of melphalan PHP. And so the tumor continues to shrink, so he's obviously doing phenomenally well. But what was really interesting, especially in this particular case example, was using circulating tumor DNA as a monitoring tool. You'll sort of notice in particular that as we're monitoring the amount of circulating tumor DNA, the levels were starting to rise, with subsequent cycles of treatment. And I'm like, well, why is that the case, right? Especially if the tumor is continuing to shrink in the liver. And mind you, and as a reminder, his disease was really just confined to the liver. So, how did I sort of use this sort of information, right? As a medical oncologist who is certainly wondering, why is the ctDNA level rising? Where in particular could the ctDNA level be coming from, particularly if his tumor is continuing to do incredibly well in terms of shrinkage from the therapy? And so what this ultimately led to was it prompted me to actually do some additional imaging. So it actually prompted me to sort of adjust a different modality in terms of how I can assess what's going on. And so what I ended up doing was getting a PET-CT scan. And what I had discovered was that he was actually found to have new bone metastases. And so that would not otherwise have been picked up that well with some of the standard imaging that I was using for him, such as the MRI and CT. And so you can kind of see here using ctDNA can actually be a very powerful tool to not only help with monitoring treatment response, but it actually can help me as a provider really prompt me to do earlier assessments with scans, particularly if a ctDNA level is rising during the midst of therapy. And in this particular case example, change in an image modality, especially if the standard of what I'm using is not sufficient enough to capture what's going on with the disease status in the body. So that was just one interesting case example. Another one is a case of a patient who I also cared for. She's in her 70s and was diagnosed with a right eye choroidal melanoma. She had a class 1 PRAME positive tumor and was treated with enucleation back in 2016. She actually, unfortunately, 6 years later, developed lung, liver, and pancreas metastases. She was HLA-A*02:01 positive, but around the time when she developed metastatic disease, her really main feasible options were immune checkpoint inhibitors. As Dr. Krainock mentioned, it's a type of immunotherapy treatment. So she was treated with ipilimumab and nivolumab, but unfortunately, her tumor actually progressed on this particular therapy. And fortunately, around the time that she progressed, we now had the availability of tebentafusp, also known as Kimmtrak as the commercial name, as an available option for her. And so what we actually ended up doing for her was we actually did a combined approach therapy. So we did both radiation therapy as well as tebentafusp as her treatment. So what was really great about her particular case was, when we did the radiation therapy, as well as the tebentafusp, we actually checked the level after she had sort of started both therapies. We actually did not get a baseline, but what's pretty awesome about this particular case was that she actually had an undetectable circulating tumor DNA. So in some ways, it gave me a level of confidence knowing that, she probably or most likely had a very low burden of disease, or maybe we might be sort of getting to a point where, she has more so just microscopic disease that we just can't detect by circulating tumor DNA testing. Now, of course, how have I been monitoring her on treatment? Well, I've been getting PET scans on her. So what I've been doing is getting a PET scan on her every 2 months while she was on tebentafusp. And what's very interesting, as you can see here, is that the arrow is actually pointing to an area that's very hot, suspected to be an area that her melanoma had spread to, in this case, her pancreas. Now, you might be sort of wondering, whoa, why is it lighting up, right? Well, we know that her melanoma had spread to the pancreas, but because we had delivered radiation therapy to that site, it's very probable that this ongoing inflammation may actually be just the residual inflammation from her radiation therapy and not necessarily from active cancer. And so the ctDNA blood testing sort of gives us sort of that level of sort of reassurance for her. And as you can see here, as I continue to get PET-CT scans, we still see that her ctDNA levels that accompany the scans continue to remain undetectable. So to some extent, it gives me, as well as the patients, a relatively high level of confidence that the disease remains under control while I continue to bentifus. Now, after the patient has been sort of on treatment for almost 2.5 years, what sort of happened was we unfortunately started to detect circulating tumor DNA positivity in her blood. And of course, we got a PET scan sort of around that time. And again, 2.5 years of therapy. And interestingly enough, I cannot find any sort of new signals or any new abnormalities anywhere. And again, this arrow points to that area of inflammation around her pancreas. And so, what did this sort of information help me with, particularly with a positive ctDNA test, was well, I got to go searching for where the heck this is coming from so that I could potentially think about intervening with a new level or new line of therapy. And so what I ended up doing was we did some additional testing and had found that she was found to have a cardiac or heart metastases that would not otherwise be easily detected by a PET scan. Generally speaking, PET scans tend to light up pretty well on the heart because it's a very metabolically active organ. And so really what did I use the ctDNA testing in this particular case was it really prompted me again to also think about a different imaging modality. And it gave me a good idea of what may be sort of a potentially false positive or abnormal uptake in a PET scan that would otherwise look like cancer, but is unlikely the case because the DNA's level is negative. It allowed me to get confidence about, okay, if it becomes positive, that's where we need to think about, is there other disease elsewhere? And of course, with this positive information here, it sort of aided me in the assessment of how the patient was doing with her current line of therapy, specifically with tebentafusp. So really, long story short is, I've been using ctDNA as a tool to complement imaging, but also using it in a way to help me identify ways to change imaging, but also think about next lines of therapy. So hopefully that kind of gives a little bit of a perspective of how I've been using this test. But yeah, I would love to see and hear how Dr. Cam Montazeri has been using this test in her practice as well.
Fascinating slides. Thank you so much. Thanks to both of you. Yeah, similarly, this has been very helpful in some of the challenging cases, especially as you mentioned with tebentafusp, because as many people may be aware, it has a very low chance of showing radiographic response. And most of the patients that actually do benefit from that, they have the lesions look bigger on the next scan that the patients have. Initially, it was a little hard to, convince yourself as a specialist and also convince others to continue the treatment while you see lesions getting bigger. And now this does not apply to everyone on the treatment, but there was also a test similarly to what Dr. Ma showed you guys. Um, Basically, investigators had collected blood samples from the patients that were treated from the phase 3 study of tebentafusp, and they looked at the ctDNA levels of these patients. And interestingly, those patients that had negative ctDNA or they had cleared out their ctDNAs early on during the treatment, they did better. And those patients that had basically any type of reduction in their ctDNA levels, they actually continued to benefit from tebentafusp despite radiographic disease progression. So in some ways, it is a very helpful tool if you don't have a better way of assessing response to disease during the treatment. It has actually happened to me as well that because as per the guidelines and also per the natural history of uveal melanoma, we worry more about the liver. And for active surveillance of the patients, most of us use some sort of liver imaging. usually an MRI of the liver, which is very precise. And sometimes, depending on how much you're worried that somebody may have disease recurrence, you also use a CT scan of the chest to also monitor the rest half of the body. But sometimes you can't see some subtle changes in the bone or somewhere else. And I had a similar case that actually one of the participants asked how we can develop this ctDNA assay if the patient hasn't had any biopsy or disease progression. If somebody has had enucleation in the past, you can use that tumor as basically a tissue to make the assay or the tissue template. So that's what we had done for that patient of mine. And yes, we saw a significant rise in ctDNA, and our detective work began. And with the PET scan, we found a lot of very small diffuse lesions on the bones. And then we started the treatment, which probably would have not been as successful if we had started the treatment later. Sometimes, unfortunately, we don't have these tools because if you have a fine needle aspiration biopsy from your primary lesion, unfortunately, that's too small, at least with the technology these days, to make a template. So there is no close to perfect assay in that setting yet. Um, However, this is a helpful tool. The other way that we have used it is that sometimes when a patient has had disease progression on a certain treatment, um, based on where the growing lesion is and how many growing lesions are, instead of changing the whole systemic therapy, we decide to add some local therapy, either radiation therapy or liver-directed therapy or cryoablation, depending on where and how many lesions we have. And there was also some evidence of additional benefit to continuing the systemic therapy in a disease that has very few effective treatment options, and adding some treatment. And you can see actually that ctDNA pattern dropping and giving reassurance to both us as clinicians and also the patient.
Awesome. Thank you guys both so much. And Dr. Krainock, thank you so much for your presentation as well. We are getting inundated with questions from the audience, so this is great. But I'm going to run through the chat first because we started to address this and I want to just make sure we clearly answer. Can this test, like the Signatera test, a tumor-informed ctDNA, be done from the primary eye tumor or just from metastases? What are you guys seeing? And I know, Dr.
Yeah.
Montazeri, you kind of touched on this a little bit.
Yeah, it depends on how much. And then Dr. Krainock is the best person. We have actually the actual person that we depend on to make the test. But it depends on how much tissue we have. With just a small needle biopsy, there is not going to be enough tissue to make that. Um, if you had a surgery to remove the actual tumor, meaning enucleation, or from the metastatic tissue, most of the time it's possible to make that assay.
Yeah, uveals, I mean, as everybody in this crowd knows, tough because there's not a lot of tissue to go around. We're always making progress on the input material needed to design. So, every year it seems like we can do it with less and less. In other cancers, we have designed successfully from fine needle aspirates, even of metastatic lymph nodes, where, you may not have a ton of cancer cells there. So we are, like I said, tumor informed for Signatera, so we do need some. We will try with very little, and we will have success. But as Dr. Montazeri has alluded to, the more we get to design from, the better the chances we could design. Um, we do have that latitude test that is tumor naive, meaning we don't need any tumor tissue at all. So that may be something that is valuable for you guys, providers and patients, in the next couple of years as we roll out our tissue naive test. So I would say we will try from pretty much anything, and we are good at small input volumes and getting better. And but we do fail to design sometimes. And uveal is one of those where it's especially tricky because there's not a lot of tissue to go around. That's absolutely true.
Yeah, for sure.
Yeah.
This question is also kind of pertaining to the obtaining a sample, using a sample. This person is asking if you had a Caris test done, um,
Uh-huh.
so like that's typically the liver biopsy, I think, for those of you guys listening who don't know. If you had the Caris test done, can they use the Caris existing test for the initial sequencing of the Signatera?
It's a great question, super insightful question. Unfortunately, no. Um,
I
so,
know.
so we have to do it. It's a great idea, right? Because there's not a lot of tissue to go around. But the way these labs, all labs are set up and regulated, right? It's very specific. You have to follow very specific standard operating procedures to stay within compliance of regulatory bodies and quality assurance metrics. And so the short answer is we cannot mix sequencing amongst companies, even amongst academic collaborators, without going through super specific and strict protocol developments. So unfortunately, whoever asked that question, that's a super insightful question. Um, and you really understand the concepts here, but unfortunately, no, we can't do that.
Maybe to also follow up on that as well, because to develop a Signatera personalized assay, you have to have, sufficient tissue to build that assay. And so, you know, I really find that biopsies or tumor tissue is just so incredibly valuable, right? Because we can use that information to do sequencing of the tumor, look for mutations that might inform treatment options down the road. And in this case, we can also use it to develop a ctDNA assay. And so, what I often encourage patients and even other providers to think about is that before you send off that tumor tissue for testing, for whatever reason, make sure that is there enough of it that could potentially be utilized for other testing as well. Because I've run into situations where if you submit it for NGS testing, there is just not enough sufficient tissue to unfortunately do Signatera testing for the patient.
One way Natera has tried to get around this, not get around this, but tried to solve this is by learning how to do the Altera that I showed in the Signatera test from the same tissue, right? So we're able to do that with exome-based Signatera and Altera today, and I hope within the year we're able to do that with Signatera genome and Altera. So then you could do what the audience participant is suggesting, right? You could take one piece of tissue, you could get a comprehensive genomic profiling assay completed and those results back. And then as a completely separate test from the same piece of tissue, you could get your Signatera assay. So within the same company or the same academic center, or what have you, it's a lot easier to do that type of stuff.
Yeah, that makes sense. And I
Yeah.
think, just from a perspective like thinking about the different biopsies and things that we have going on as patients, most
Mhm.
patients at the primary tumor stage, like with the eye tumor, are mostly having the Castle Biosciences test,
Mhm.
which has been proven, to be a really good genomic sequencing. But it would be really, really interesting to see if over time we could, start using those needlepoint biopsy, and if they could just take two samples at the needlepoint biopsy point, like when they do brachytherapy,
Mhm.
like doing the plaque, and just basically kind of have the providers be aware of the like Dr. Moss said, like be aware of the kind of the range of tests available, and to
Yeah.
try to make sure that you get, as much information as possible from that one time that you're biopsying.
Yeah, no, absolutely. The, it's we're always up against this in almost all cancers now, right? We're getting less invasive and we're trying to do more stuff.
Mhm.
So we're able to make diagnoses based off of more minimally invasive approaches. But the list of things that we need to do with that tissue gets longer every year, which is a good thing, right? It means we're learning more about the cancer, but it's a conundrum because we're trying to do less for acquisition, but we're trying to do more with what we get. So it's a balance.
Yeah, absolutely. Okay, so let's see. I think we've kind of covered this, but just to clarify, if a patient was treated a few years back and there is no tumor tissue to biopsy to make the tumor-informed
Uh-huh.
Signatera test, how can a baseline be established? I guess my understanding is you can't establish a baseline at this point for the tumor-informed test.
That's right. Yeah, for
Okay.
Signatera, we couldn't design you a Signatera. In the near term, we may be able to design you a Latitude.
Okay. Let's see. Signatera negative, like Signatera negative with a positive. Okay, so this is an interesting thing, and I've actually had this happen as a patient myself. For those of you guys
Hmm.
listening, if you didn't know, I'm also a metastatic uveal patient. So, this patient is saying, what about patients who are ctDNA negative, but have a positive tumor burden in the liver? Like all of them are small, less than 8 millimeters. Do we understand why metastatic uveal melanoma is kind of like a low shedding tumor or like low shedding disease? Like ultimately, why could you see disease on an MRI in the liver but not be picking up the residual or the Signatera?
Yeah, it's a great question. And I'd love to hear Doctors Ma and Montazeri's thoughts. I'll give you, just briefly, it's in the setting where we have radiographically evident disease that's tissue confirmed, meaning we know those sub with 8 millimeter sub-centimeter nodules are cancer, right? And they're not treatment effect or fibrotic change or what have you, right? It's actually better to be negative than positive in that scenario, right? Because it means that the biology, at least at the time of the blood draw, was the biology now was less aggressive than the same patient who has a positive result, right? Because remember, if we're going in the arm and getting a sample of the peripheral blood, right? So for the test to be positive, that tumor has to be elaborating DNA out into your bloodstream. And that is typically associated with more aggressive behavior, right? It's doing things, it's turning over, it's elaborating DNA into the blood at sufficient levels for us to detect. When you have disease you could measure and see on a scan, but that's not the case, that usually infers that at that time the biology is actually less aggressive. So it's more indolent. So in a genome world, right, when we're using the genome test now, I think that scenario will be less common because I think we'll be able to detect those indolent low shedding tumors at even lower levels. And so if we come back and we talk in a year or two, I might be saying the same thing, but now I might be talking about the quantitative value of ctDNA being prognostic rather than positive or negative. I hope that makes sense. And I'd love to hear Doctors Ma and Montazeri.
Yeah, I agree. There is a threshold that you can detect basically those copy numbers in the blood, and with a different technology, which is always a trade between those sensitivities and how basically confident you are that what you're catching is real. So if you do a deep sequencing, you may be able to catch a very small amount of DNA shedding to the blood, but that is always a good sign that the tumor is not actively growing and replicating too fast to shed it to the bloodstream.
Yeah.
Yeah, I
In
think
a sense, it's a good problem to have.
Yeah.
absolutely. I mean, it's always good to have in my opinion, and we know that having a negative or undetectable level is very good in terms of prognosis. But I've certainly had those types of scenarios where we have a scan and a biopsy that confirms active disease despite a negative ctDNA level. And sort of how I like to describe it is, we really have a relatively low burden of disease that we just cannot detect it at that very moment in time with the ctDNA assay. And so that's kind of how I sort of frame it, with patients is yes, even though we know there's active disease, but we can't detect it by blood, that doesn't mean you don't have cancer, right? The other thing I also describe, and something we've also published, over the past year or so, is that, the sensitivity of the test, specifically for melanoma, we've learned that, depending on the location of where the disease is, you may have a higher probability of being able to detect it. And so, for example, the most common areas that we've published and learned from is that if you have disease in the lung, the lymph nodes, liver, there's a higher chance of being able to detect it more so than if the disease had essentially popped up in the skin or in the muscle or in the brain, for example. So I think melanoma probably has an interesting biology where it has the ability to shed DNA with better, easier detection than other locations, depending on where it is in the body. But as you can imagine, I think this is really a call to action to really enhance the technology to better detect, cancer in the blood. And it's very interesting to see, like companies like Natera sort of developing and making their tests a lot better. transitioning from an exome-based to a genome-based type of assay so that we can hopefully increase that sensitivity and make it more reliable for monitoring.
Yeah, absolutely. So in terms of this monitoring and kind of like the use of the test, one of the questions from our a patient Michelle is asking, I'm currently like a stage or I guess just a high risk tumor profile, so probably a class 2 tumor or just higher probability of progression, and there's not currently any adjuvant therapy that's being offered for my situation. Um, I've been told by my oncologist that ctDNA wouldn't help as there's currently no treatment available anyway. How could I potentially use this test at my stage?
So I
Do we
don't
have
know
room?
from the question if this patient had a nucleation, or are they talking about, a basically a cell-free DNA panel, like a genome sequencing panel without a tumor tissue. It depends on that. If we are talking about, Signatera, we can use that in addition to surveillance scans as a method, another layer of information basically for surveillance. There have been some situations that, for example, if you have a standard of care option like tebentafusp, the sooner you start the treatment, you're not going to lose anything. If really there is a very small lesion that is difficult to biopsy, and you have proof that there is disease recurrence, and start the treatment. On the bright side, if you have negative scans and negative ctDNA, that's another layer to reassure you that there is no evidence that you have cancer recurrence. But if you don't have that, do not worry. I'm sure your doctor is monitoring everything closely.
Well, and like, I
Yeah.
mean, 5 years ago, 6 years ago, we didn't have ctDNA as a reliable marker to use as, like Dr. Montazeri said, that extra layer of information. So, it's not that we don't have surveillance available. We still have surveillance as patients. We still have Dr. Ma, Dr. Montazeri, other oncologists who they're prescribing scans, like they're doing lab work for other inflammatory markers. Like, there's still going to be monitoring done. So if ctDNA isn't something that can currently be used right now because the tissue isn't available to make the test, that seems like at least in this patient's question, that's probably more of the case is that there's just not any residual tissue to use. And if you don't have that, then waiting on that longitude or latitude test, is that what you called it, Dr. Krainock?
Latitude. Mhm.
Latitude test. That's an option. Just keep watching for that to come out. Keep an eye out in the Signatera world. We have, another question that came in asking about Trillium Bio and Oncobit, who are launching advanced uveal melanoma ctDNA testing called Oncular. Like, do we know of like how many companies, I guess, currently offer ctDNA tests, and what's the difference between them? And if it's okay, I want to ask Dr. Ma this question because we kind of talked
Sure.
about this in our podcast.
Yeah.
And I don't know that we can put a number on it, for one. um, I don't know that we could say the exact number of companies that have a ctDNA test, but Dr. Ma, do you want to go ahead and define the difference? Like, I guess
Yeah.
just yeah, go ahead and just share what you would like about that, and then I'll tease some other answers out of you if I need to.
Yeah, absolutely. I mean, as you guys know, I think ctDNA is sort of this hot new thing that we see in the oncology world. And we're using this test, and it's absolutely exploding in the field of how we use it and what settings, whether it's for treatment monitoring, for surveillance. And so you can imagine it's definitely become quite a competitive space. And I know there's a variety of different companies that are developing their own ctDNA testing. And so I think, how I sort of categorize, sort of the two main types of tests for ctDNA. There's the tumor informed, such as the one, like Signatera, where you actually have to go back to the actual tumor tissue, look at the DNA changes and personalize the test for the patient. Whereas another type of ctDNA test is tumor agnostic, meaning that you don't necessarily need to go back to the patient's tumor tissue, but you're actually developing a test based on what we know the mutation is likely to occur because of that specific tumor. So, for example, for uveal melanoma, we know about 85 to about 90% of the tumors are GNA11 positive or GNAQ positive. And so you can just right off the bat just develop a test that specifically looks for that mutation in the blood. So it's another way to do it. The tumor agnostic method is another method to monitor, for ctDNA in the blood without relying on tumor tissue. The person who posed that question on the question there about Trillium Bio or Oncular, it is a relatively new test that has recently just become, my understanding is commercially available here in the United States. It only just recently became available, I think, this past month. And so I'm certain there's a lot of excitement. And I think many of us in the uveal melanoma community are excited to learn a little bit more about it. But that might be a potential option that we may consider for some of our patients. And my understanding is that Oncular or Trillium Biotest is a tumor agnostic test.
Okay, awesome. I do want to move on for time. We've got about 10 minutes left before we've got to wrap. But just as a, from an oncology perspective, Dr. Ma, Dr. Montazeri, what made you start trusting ctDNA enough to use it regularly in your practice?
Well, so first of all, no, there is no perfect test. We don't have any test in medicine that has 100%, capability to detect a disease or exonerate that you don't have the disease. So there is always a chance that you get a test that is falsely positive or falsely negative. Add to the point that one of our participants mentioned that they have small lesions in the liver, that ctDNA has been negative. It's good. It's a good problem. On the other hand, there are some situations that we have multiple small lesions that are growing. And if we rely on the blood test solely, we may be falsely reassured that there is no disease or there's no disease progression, whereas you can see on the scan that actually there is evidence of new small lesions every time. So I'm happy that there is a very basically effective and sensitive tool, but we have to also be cautious not to rely on just one test. And we are still in the phase of collecting information on how to use ctDNA. This is not something that has been approved for this indication. It is great that, it's not a financial burden for the patients to get this test, but we should also always continue to use the methods that have been validated based on data that has been more available in the future. I'm sure that, all of these tests are going to improve even further. And until then, we should make sure that we use different methods together, not to miss anything.
Yeah, absolutely. Dr. Ma,
Yeah.
do you have anything to add?
No, I think Dr. Montazeri highlighted very important points, and I completely agree with her. ctDNA testing is something I, again, offer to my patients as an optional test at this time, right? Currently, the current standard for, surveillance as well as treatment monitoring continues to be scans, right? And while it's exciting, particularly where we're at now with using ctDNA testing in the cancer world, and we've seen, approvals and this reaching the guidelines for using as an optional test to complement imaging. We haven't seen so much of that success quite yet, I think, with melanoma. And I think part of it is because, we still need some additional studies, prospective studies, integration into clinical trials so that we know, can this test be a reliable and accurate marker to be informative for physicians as well as patients and really inform treatment decisions, right? But for the time being, I think this still continues to be an area of ongoing exploration. And how I've been using it has really been to more so complement, the testing that I'm doing. So biopsies, imaging, right? At the end of the day, those are still considered the gold standard. But overall, my trust in this particular test has really just been, through experience, trying this out on patients who are willing to participate and having this test done and making some really interesting observations. And having patients do this gives us an opportunity to publish these results and hopefully validate the use of this test in real world clinical practice.
Yeah, I love it. Dr. Krainock, what are some of the, maybe just general unanswered questions about ctDNA in regards to uveal melanoma that you guys are kind of still trying to figure out? Like, I guess, like, do you guys have a good direction of where you're wanting to go with like something like uveal specifically?
Yeah, I think the use cases for uveal share a lot of commonalities with other use cases, right? We want to know in patients who've undergone definitive therapy and are in surveillance, is there a benefit to using ctDNA during that surveillance? Can we either change our approach to surveillance using other tools such that we identify intervenable disease earlier and more often? And or can we actually treat on the signal and help patients live longer? And then in patients who are actively being treated for, say, metastatic disease, kind of like I alluded to in the slides, can we be an early warning system for regimen failure? And can that early warning system serve as a trigger to change things? And can that help patients in terms of their progression-free and overall survival? So I think those are really exciting opportunities where we think we could help patients and improve outcomes. Uveal melanoma, as this group knows, is a rare tumor. So we work with great collaborators like Doctors Ma and Montazeri to generate data in sufficient numbers to drive those types of use cases and drive the adoption.
Yeah, absolutely. And I think that, on the flip side of one of the things that you said, ctDNA, I think Dr. Montazeri, you mentioned this, ctDNA, at least in uveal, from what you guys are sharing, has sometimes been an indication. And I think even Dr. Krainock, you mentioned this in your presentation, that, if you're seeing a good response to ctDNA, even if the imaging is showing some level of like small disease progression or something like that, that can be a reason to, instead of like jumping off the treatment, that you stay on it a little bit longer and kind of wait it out, see what happens. And I think Dr. Montazeri, you mentioned like specifically around Kimchak that sometimes you don't see the correlation in the scans, but you are seeing continued benefit. You're seeing, that the patient is having a good response in the ctDNA, and that benefit just kind of shows up in the scans later down the road. Okay, so oh man, you guys have so many good questions. I love it, but I also, I don't have time to cover all of your guys' questions, so I want to see if we can cover just a couple quick ones. Um, this is actually, there's two questions I want to combine, and I think Dr. Cranock, this is probably more for you, but is ctDNA as effective at picking up the molecular residual disease if you don't have a complete set of biomarkers from your tumor sample? That's
Mhm.
part one of the question, and then I'll ask part two in a sec.
It's a great question. Like, if we can't design against the full complement of mutations we typically do, I guess the first thing I'll tell you is usually we can, but if we can't, for whatever reason, we actually have pretty well preserved sensitivity and specificity before we really start to drop variance and get down to like, a three-quarter full assay, so to speak. We'll start to see drop off at patient level performance. I don't have a ton of data there because we can usually do it. But suffice it to say, if this individual asking the question already knows, that they can't get a full complement, typically performance is fairly well preserved in my experience until you really get to like low variance on the panel.
hmm what about like failed ctDNA because of low plasma? What does that mean
Low
in terms of,
plasma.
yeah, like that's, I guess this is the specific situation. I don't know if this is unique to the Signatera test or just a different ctDNA test, but they've been told that the ctDNA failed because of low plasma in the blood. Do you guys, anybody know what that means, or do we not really know?
I have
I've never
not
heard
heard
of
that.
that.
I have not heard of that. All I could think of is that the volume submitted to whether it was us or somebody else was insufficient,
Okay,
insufficient
yeah.
plasma. So just make sure that the kit directions are being followed, whatever test you're using. Follow the directions for the draw on the kit, and if reach out to the company if they're not clear.
Mhm. Yeah, and I've had that happen before. I don't think it was noted as like it just said no, like sufficient sample size not obtained. Like please retest. That was the
Yeah.
message that I got at least in my Natera portal. This person wants to know when the latitude testing becomes available. I don't know that you had a specific date for that yet. We just
Hopefully,
are in the near future.
hopefully this year.
Okay, hopefully
I
this year.
can't I
So
can't
just
guarantee
keep an eye out.
can't guarantee it, but hopefully this year.
Okay. Um, Let's see. Let's see. I do want to cover this really fast, just from our doctor's perspective. Okay, we know that there's, this kind of scanxiety that patients go through, that like extra layer of anxiety related to having scans, having your MRIs, ultrasound, whatever layer of modality that you're having for surveillance. Um, Dr. Montazeri, Dr. Ma, how are you guys seeing patients kind of emotionally cope with the variability, right? The roller coaster that sometimes ctDNA can look like as you're using the test more regularly.
Yeah, that's a great question, Danae. And so, over the years, I've learned, especially as I'm asking patients if they want to undergo ctDNA monitoring, and that we know sort of the risks and benefits, right? As we're waiting for this test to be, further validated, be integrated into guidelines, it still remains an area of ongoing, exploration in its use, right? And so what I often say from time to time, especially with these results, is that, sometimes you have to take them a little bit with a grain of salt. Say, for example, we've ran into the example where there's active tumor in the body on scans and biopsy, but it's negative, right? And so those scenarios can come up as we're utilizing and integrating this test into clinical practice. But well, most important thing I also mentioned is, these results can sometimes cause a great deal of anxiety, kind of waiting for that result to come back, about a week or so later, can provoke a lot of worry for patients. And that's something I actually discuss quite a bit with patients when we decide whether to integrate the test into monitoring. But long story short is, I think after discussing a lot of that, I think most patients would rather know rather than not. As I mentioned, it is intended to be used as a complementary test, and we still need to, again, be very cautious about how we interpret it because again, it is still an area of ongoing research.
Yeah, absolutely. Dr. Montazeri?
Yeah, I totally agree with what Dr. Moss said. It is like any test, having a good result is reassuring. Waiting for that brings anxiety, living between the two scans and also dealing with the non-desirable results. There is no easy way to reassure one person who's going through this. It is different, of course, I'm sure, for the patients than for the healthcare providers, for the doctors. One thing that I reassure them is that, we are monitoring things as closely as possible. So we are doing whatever that needs to be done for this cancer. I don't want this to take over your life. I don't want you to, just um, sit at home and just think about what's going to happen on the scan or what am I going to do. There is nothing else that you need to do other than showing up to your appointments, and we're a team and we can figure this out together.
Absolutely. I love that. Okay, well, I think there's one last technical question. And I think that this is the answer to this, I can guess, but I'm going to let Dr. Krainock and Dr. Ma, Dr. Montazeri kind of weigh in here. If you're having ctDNA done and you're seeing like kind of a low number, right? Like on the scale, like I know sometimes the results scale, Dr. Ma, the slides that you showed, you had one ctDNA test where it showed like a range from 0 to 100, and you had results in there that I don't know quite what it was measuring, but like I've seen patients with ctDNA that measures, 150, and then I've also seen patients that measure like 1.5 or zero point zero 0.03. Um, do you guys have kind of a way of determining low tumor burden using the ctDNA test, or is that still kind of like an evolving researched answer? Dr. Krainock, I don't know if you've got any insights there.
Um, so I kind of set the scale in my mind per patient.
Hmm.
So I let the patient kind of, is it high for them or low for them, right? So like, you know, 80's high and 1,000's high. I've seen both. Right. So, but not commonly. So I think of it within the patient. I don't know across patients, certainly in melanoma, if we have enough data to stratify what's high and what's low, like as a group, as a categorical. So I think about it more within the patient.
Yeah, and I'm seeing Dr. Mon nodding.
Yeah, I mean, I would say just based on observations that I've seen, having ordered this test, on patients in a variety of different settings, and I think, of course, this is something we need to continue to publish on. Is I have seen, some correlation between higher disease burden with a relatively higher measurement of circulating tumor DNA.
Yeah.
Whereas, lower disease burden, more likely to have lower or even, sort of undetectable. I don't know if you remember, Danae, when we did our webinar where we talked about like the analogy of ctDNA, right? I kind of call it like poop, right? The analogy of calling ctDNA as poop. It's basically a byproduct that, essentially you can measure, right? A waste product you can measure in the blood. And so if you have a great deal of active or live tumor, you're able to measure that much more reliably than if you have dead tumor where you're not making byproduct or waste product, in this case,
Hmm.
poop, then you're not going to be able to measure that quantifiable level. So
Yeah.
that's how I've been sort of seeing as how ctDNA is, and like what we're actually measuring is we're actually measuring indirectly live tumor cells in the body.
Yeah, that makes sense. Um, Kind of on the, I apologize, I'm kind of teasing some tricky questions for you guys, but have you ever seen in your practice like ctDNA rise dramatically and then drop immediately after, like, say, Y90, ablation, Hepzato, like the PHP treatment? Are you guys noticing anything like that ever? And if so, like, I mean, what does that mean?
So one of the interesting features of ctDNA is the half-life. The half-life is 30 to 90 minutes. So you could certainly see a spike, I believe, if you drew when a lot of cell death was going on, which is exactly what we want to see, right? But that signal is going to be gone super quick, right? So 30 to 90 minute half-life means that in 30 to 90 minutes, half of it's gone, it's been degraded. And then double that time and it's all gone, right? So yes, I believe you can see the phenomenon you're describing, but I think that we don't see it just because the half-life's so short. So you would have to really time the draws super,
Yeah.
super specifically to
You
do
would
that.
have to be like, okay, like you did Y90, now you're doing a
Yeah.
draw, and then 30 minutes later to a draw. That would be an
Yeah.
interesting correlation to see. I just know I've heard of just a few random patients who they were like, oh my goodness, I had Y90 done, and then my ctDNA spiked to like 500, and then the
Hmm.
next time they drew it, it was all the way down to zero again.
Yeah.
Yeah.
And obviously, the time between those draws was probably a month. So that
Hmm.
was all hopefully, enough time for that, like you said, that half-life to disappear. But I
Yeah.
just I think that's a really interesting phenomenon that kind of
It is.
correlates to the idea of like cancer poop. I guess like my mediocre understanding of biology says that cells that grow discard, right? They discard cell waste, and cells that are dying discard cell waste. So you might have cancer poop that's coming from cells that are just actually continuing to die, or you might have it because it's really, really actively growing and continuing to discard, everything it's not using to grow. Um, I don't know
Yeah,
if
it
that
may
makes
be
sense.
poop plots the cells that already pooped and died uh,
Mhm.
together. So yeah, I agree with Dr. Krainock and Dr. Moen. I also wanted to add, and also to your point, Anna, that it depends on what type of treatment we're talking about. There are some treatments that have a gradual effect. For example, if radiation therapy or Y90 we're talking about, it doesn't kill the cells right away. So
Hmm.
it may be a gradual thing. That said, we have seen this pattern that we actually did ctDNA testing, not necessarily with Natera, but we were curious to see if this happens with radiation and how soon it happens. And usually a few days after radiation, we see a spike, and then it gradually goes down. Better to do the ctDNA as a baseline right before
Hmm.
giving the Y90.
Yeah, that
Yeah.
makes sense.
Or
Agree. Another example would be, if you surgically remove the tumor, from the body, we do that on occasion from time to time, depending on stage of disease. But, if you have a high level, and once you remove the only source of where the DNA is coming from, you can see that level drop, quite dramatically. Even in some cases, it can go down to zero.
Yeah, absolutely. All right. Well, okay.
Mhm.
Last question for patients who want to know more about ctDNA, specifically about the Signatera test. Where should they go for information? And then for doctor perspective, if you are a patient who doesn't see Dr. Montazeri or Dr. Ma, or a patient, a doctor who currently utilizes something like Signatera's test, how could you go about bringing this up to your doctor if you're interested in having this test done? So doctors, keep that in, park. We're going to answer that in a sec. Dr. Krainock, in honor of your time, I want to let you answer that question for where they can get more information.
Yeah, so you could visit the website, natera.com. You can also reach out to me directly. So my email is my first initial and last name at natera.com. So M Krainock natera.com. Shoot me an email. If you have
Awesome.
specific questions, if you just want to generally learn about the test, visit the website. We have all kinds of patient downloads and brochures. One thing I wanted to mention, I saw something about, I think you touched on it, Danae, a question about slides. If the patient's talking about slides that a pathology department has, we can use slides. So we can scrape the slides. So I just don't want to confuse people. We can't use sequencing done by another lab. But if you're talking about your tumor was sectioned and put on slides, like every tumor is, and it's sitting in a pathology department, but the block's been exhausted, it's just slides. If that's what you're describing, we can use that. Just FYI.
Okay. So
Michael,
that's,
you
worth
mean the
exploring.
unstained slides, right? Just
Unstained, yeah. One H&E, yeah, and the rest unstained. I think we need at least one H&E. Yeah.
And it kind of just sounds like if you're not sure, right, that you could have your doctor investigate and also connect with Natera
Yeah,
to just make sure
that's a
that,
good point.
that they can clarify, like, okay, if there's some level of disease sample available, is this
Yeah,
usable for the test or not? And just kind of
that's a
let them.
that's a great point. It's not up to the patient to go figure that out. If you're interested, our team will find out for sure. That's a really good point today.
Awesome. Okay. Dr. Montazeri, Dr. Ma, patients who don't see you or don't see a doctor who uses Signatera or a ctDNA test, what would you say to them bringing this to their doctor and like kind of how they could approach that?
I guess I could start. So I've been a very heavy user of circulating tumor DNA in my practice, but I would say not every provider is, even familiar with it, and so having this sort of like webinar here, podcast, I think a lot of patients are starting to learn about what are their options, in terms of like cancer monitoring. And so, for patients who are interested in doing things like ctDNA monitoring, whether it's for surveillance or treatment monitoring, I say start off by at least asking your provider. I think nowadays with ctDNA being so heavily used, in a variety of different settings, not just melanoma, but for other cancers, I think every provider at this point is at least familiar with it. And it's an opportunity for them, especially if they don't have it available in their practice, to push themselves to look into it and potentially bringing it in as an option to their clinical practice. And so, as usual, Dr. Montazeri and myself, we're primarily at academic centers, where we're always pushing the limits in terms of research, innovation. But it's never wrong to get great care as well as in the community. And even though they may or may not have the test available, it's always reasonable as a patient to always ask, what are my options? Can I do something that is available out there, especially for something like Signatera, which is commercially available?
Yeah, absolutely. Okay. Well, you guys, thank you so much for your participation as our audience. We could not do this without you guys. You guys have been a wonderful audience. If you guys are listening to this recording on our edited YouTube channel, then please make sure you're dropping those questions in the description or in the YouTube chat later, and we will do our best to come back and answer those questions. But for now, let's give a huge thanks to Dr. Krainock, Dr. Montazeri, and Dr. Ma for being our guest speakers here and just having this discussion with us. And again, huge thanks to our sponsors. Natera, Castle Biosciences, Aura Biosciences, Delcath Systems, IDEA Biosciences, and Immunocore for making sure that our webinar could happen. And we look forward to seeing you guys for quarter 3. In the meantime, we've got ASCO to look forward to this summer. That's a lot of the doctors are heading there. I think all 3 of these doctors are actually heading to ASCO next week in Chicago. If you're not familiar, ASCO is one of the biggest cancer like research conventions where people are presenting, abstracts, they're presenting research, they're presenting clinical trial data, if we have any that's matured, like all of those kinds of fun things. So stay tuned with a Cure Insight. We've got Ion Research happening at the end of July, maybe beginning of August. So make sure to stay tuned for that, and we will see you guys next time. Bye, guys.
Everybody, thanks.
Thank you.